Ladies and gentlemen, you're all aware that choroidal neovascularization is a situation where there are these abnormal choroidal vessels, new vessels growing under the RPE, break through, reach the subretinal space, and then can cause problems for us. When do they occur? They can occur because of age-related macular degeneration, high myopia, they could be inflammatory, or they could be idiopathic. However, since the majority of these cases is because of ARMD, the stress would be there, and the basic principles of management can then be transposed to the other conditions also. What is it that you see in these patients? You have a leakage of fluid under the retina and into the retina, and or subretinal or sub-RPE hemorrhage. What you see here is a subretinal hemorrhage, and what you see here is a sub-RPE hemorrhage. And these are the various pathologies which result in the vision loss in these patients. The patient presents to you basically with blurring of vision, but specifically with a scotoma or metamorphopsia. Just for the audience, how does it feel to have a scotoma? If you can't see your sweetheart, that's one problem. If you can't see the face you wanted to recognize, it's a big problem. If the ball you wanted to hit suddenly becomes distorted, it's a big problem. And the problem is, this is always the center. It is not the periphery of your field. The peripheral vision often remains normal. So the basic thing is, patient never goes blind completely, but he loses the ability to read. He loses the ability to perform tasks which require detail. And this is what the Amsler's grade would look like. Choroidal neovascularization could be classic, occult, or minimally classic. What you see here is a classic neovascularization where you have a network of vessels visible in the early phase on fluorescein angiography, and the hyperfluorescence keeps on increasing in the late phase with blurring of the margins. But more than 40% of your patients will be occult CNV, where the early phase there will be no leakage, and there's late leakage from an unknown source in the late phases of the angiogram. Another form of occult CNV could be a fibrovascular PED, where there is a stippled fluorescence within 1 to 2 minutes, and this persists in the later frames. And the last is what we call a serous PED, a serous pigment epithelial detachment, where in the early phase itself, the lesion fills up. In the late phase, the margins remain absolutely clear, but the intensity of the fluorescence increases. You're not interested just in what kind of lesions are there. What you want to know is, what happens if I don't treat? Well, if you don't treat your patients, and this is from the TAP and the WIP study, which was a decade earlier, you can find a loss of more than 6 lines in half the patients within 2 years, both in the classic and in the occult lesions. And the minimally classic lesions follow the trend of occult lesions. In fact, if you see how many go blind, in classic CNV, in the predominantly classic CNVs, more than around 70% of patients will get a vision of less than 20 by 200 within 2 years. In occult, it's a slower progress, but still around 45% of patients would have gone blind within this 2-year period. So it is something which is a drastic loss of vision. How should you approach your patients? The fact is that there will be some time when you say, oh, this doesn't look like a wet ARMD, this is dry. Even in these patients, you must do an OCT, because sometimes you may pick up an early exudative ARMD by doing an OCT, and that changes your approach to management. The basic investigations you need are, of course, as you saw, the OCT and the fluorescein angiography. The fluorescein angiography not only characterizes the subtype, which helps you to prognosticate and see whether it's healing, but also tells you whether the lesion is extrafoveal or subfoveal. Subfoveal lesions can be easily treated by a focal laser, and even today, the most definitive treatment available to us for treatment of CNV is a focal laser. It destroys the CNV completely. However, for subfoveal and juxtafoveal CNV, the initial treatment of choice is anti-VEGF agents, and this is the mainstay of your management. The gold standard for this is Lucentis, though Avastin and aflibercept have now become available. When you start the treatment in all active lesions, you must give 3 loading doses at monthly intervals. And this is regardless of visual acuity. Sometimes a patient with low visual acuity may improve to a very good vision. So you must treat all these patients first with 3 loading doses. After you've given the first 3 loading doses, what do? You could have different situations. The first situation is very rarely in a small lesion. You could actually have a patient who healed by the first or second treatment. In this case, you complete the loading dose and then put the patient on PRN treatment, which means you follow up the patient and give the treatment wherever the patient again has a recurrence. Some patients may resolve at the end of a 3rd injection, and here too, you must give at least 1 more injection before you say, well, now you can go on to a PRN treatment. But then there are at least 80% patients who will not heal after the 3rd injection. These patients will continue to need monthly injections till either the lesion heals, in which case they move on to 1 more injection and PRN, or they may reach a stable state. Now, what is a stable state? A stable state is a situation where the OCT becomes, the picture remains stable month after month, the vision does not change, but no improvement, no worsening is occurring. Once you've reached a stable state, this is a group which is possibly a better indication for a treat and extend regime, where you extend the period between injections. Normally the injections are given at 4 weekly intervals. You increase it to 6 weekly, the patient still stays stable, you go to 8 weekly, still stays stable, you go to 10 weekly, and so on till 12 weekly intervals. But quarterly injections still need to be given as long as the lesion has not healed. It's very easy to give an injection. It's more difficult to hold your hand. The question is when not to treat. There are conditions where you need to hold your hand. And if you see all studies, they'll mention one term which we miss, which says progressive occult lesion. We seem to miss the progressive part. The fact is that if you have a non-progressive serous retinal RPE detachment, or you have a serous RPE detachment with good vision maintained and no vision loss, this is an indication to hold your hand. There is also a situation where you must know that you've done all you could have. So a situation where you have a macular scar with worsening to a point that the visual acuity is less than 3/60, and this is the worst eye, don't waste this patient's money. Let him conserve it for the other eye, and let him conserve it to preserve his style of living. This is one kind of lesion where treatment would not be indicated. Even in a scar like this, if these hemorrhages were old, have been resolving, and there is no activity, you don't need to treat this anymore. And finally, even where there's a RPE detachment like this, the macula is normal, minimal metamorphopsia, and the vision is 6/6. If the patient is not progressing, please do not treat this lesion. With the treatment approach we are talking about, can you do anything? Can you make a difference to the patient? The fact is yes. All studies have shown that 2 years, 3-year outcomes are excellent with anti-VEGF agents. You can achieve a 10-letter mean improvement in many of the studies. Of course, the gold standard for this has been monthly treatment. So month after month, the patient has got the treatment. But if you follow up the patients regularly, you could come close to this kind of approach even with PRN treatments. But what happens in the long term? The unfortunate thing is many of our patients come early. They come at an age, whereas in the Western world you see them at 70s, 80s. Sometimes our patients are in 50s and 60s. But the longevity has gone up. The patient may live for 10 years. So what is the long-term outcomes we have? Well, if you see, this initial study means the Marina and the Anchor study. And then there was a follow-up study, the Horizon study. And you see, in the gain of 10 letters started going down in the Horizon study, and the 7-up study, which is a long 7-year study, it went down further. So what happened? What happened was that at the end of 7 years, that means long-term results, what can you achieve in these patients? You can still help at least a quarter of the patients to maintain a vision of more than 612. You can ensure that 1/3 of the patients have a vision of better than 618, which means they can even actually do most of their routine activities. But there is a 1/3 group which will get more than a 3-line loss. And at the end of 7 years, you find that 70% of the patients are still active. You find that treatment is still going on in 50% of the patients. So what is the lesson we want to give? What is the lesson we've learned? Monthly follow-ups are essential. In the Horizon study, the results went down because they went to 3 monthly follow-ups. The moment you go from monthly follow-up to 3 monthly follow-up, the patient deteriorates. So monthly follow-ups are essential till the lesion heals, and then 3 monthly follow-ups lifelong. The second and most important thing, you have to have a very high index of suspicion for retreatment. Any loss of best corrected visual acuity of more than 5 letters, any OCT evidence of new macular fluid or persistent fluid following the last injection, any increase in the central retinal thickness by more than 100 micron, any macular hemorrhage which is new, and any subjective evidence of macular fluid. So this is the extent of suspicion. The ophthalmologist feels nahi kuch badh gaya hai. Even this is enough an indication for giving retreatment. And if you are this vigilant about your patients, if your patients take the pains to come to you regularly for follow-up, you can help to save the vision for a lot of